Next speaker is Dr. Sushma Tejwani. She is from Narayan Nethralaya, Bangalore, and is a very versatile speaker and surgeon. She can talk on any topic of glaucoma, and she's a great researcher. So over to you, Dr. Sushma.
Thank you so much, Dr. Manadi. You're being very kind to me. I'll try to share the screen. Well, at the outset, I would definitely like to thank Dr. Tanuj Dada and Dr. Namrata Sharma and APGC and AIOS for giving me this opportunity. So I have put together a case and certain tips for taking care of Bleb rupture during phacoemulsification. It has a voiceover, so I'll be just playing that.
This video demonstrates intraoperative bursting open of a filtering trabeculectomy bleb during phacoemulsification and its management. A 45-year-old male presented with decreased vision in both the eyes and had history of trabeculectomy bilaterally 15 years back. Right eye was blind since then. In the left eye, there was high filtering thin bleb, nuclear cataract with hypotony along with advanced glaucomatous cupping. Left eye was the only seeing eye and the optic nerve appeared pale with hazy view of macula. There was advanced visual field loss even on 10-2 program. The bleb OCT showed large hyporeflective area suggestive of high filtering bleb and a thin bleb wall, as thin as 20 microns at some places. He was advised left eye cataract surgery under guarded visual prognosis. Situations like this amount to almost like walking on a tight rope where a little imbalance on either side can be disastrous. Hence, due precautions were taken even while giving peribulbar block to avoid undue pressure. While draping, speculum was applied gently to ensure safety of the bleb. To begin the surgery, the side port incisions were made, avoiding the bleb area. Viscoelastic was injected to form the anterior chamber. A continuous curvilinear capsulorhexis was performed using a bent needle cystitome through the side port. A temporal clear corneal incision was made using a 2.2 mm keratome. Hydrodissection and hydrodelineation were performed with slow fluid waves, thereby avoiding possible intraocular pressure rise in the anterior chamber. Nucleus was freely rotated in the bag. Phacoemulsification was performed with low fluidics parameters, that is a low bottle height and a slower aspiration flow rate. A stop and chop strategy was employed to crack the nucleus, followed by aspiration of nuclear fragments. All these maneuvers were done keeping the fluidics low and being gentler to avoid inadvertent trauma, keeping a watch on the bleb. All was going well, but then there was a sudden change in the situation, like bursting of a balloon. And yes, the bleb gave way. As the epinuclear plate was being aspirated, a sudden fluid jet was noted through the bleb. However, the chamber did not collapse totally. This happened probably when occlusion broke suddenly at the tip of the probe. This suggested that some weak area of the bleb wall had given way to the fluidics pressure in the chamber. The procedure was continued with the aspiration of epinucleus and cortex with further lower parameters. This was followed by implantation of a foldable intraocular lens in the bag. Viscoelastic was then removed and the anterior chamber was formed again with BSS. The site of leakage was identified and the quick swelling up of cellulose sponge suggested a significant leak. The margins of the defect appeared too fragile to be held, as the avascular tissue would give way, leading to a larger defect. Hence, I decided to use fibrin glue instead of sutures. The anterior chamber was filled with air to keep the area of leak dry. A preserved amniotic membrane graft was immediately called for and fashioned to the required size. Both the components of fibrin glue were applied over the bleb. The amniotic membrane was immediately transferred over the bleb with stromal side facing down. After waiting for a couple of minutes for glue to dry, the excess graft tissue overlying the cornea was excised to keep the visual axis clear. The graft was then anchored to the surrounding healthy conjunctiva with atovicral sutures. The graft margins were kept away from the bleb margin in order to avoid any further injury and to achieve a secure attachment of the graft. At the end, surface and free limbal margins were again checked to ensure that there is no leak. Also, a formed anterior chamber was confirmed while removing the speculum gently. On first post-operative day, the patient was doing well with a quiet eye and a formed anterior chamber. A Searles test was performed at 2 weeks to detect any micro leak and was negative. Fundus was clearly visible, CD ratio appeared 0.6 with pallor, and the bleb OCT was carried out again that showed a shallower hyporeflective space with somewhat thicker bleb wall. At 2 years follow-up, the bleb maintained filtering function with a deep anterior chamber. The intraocular pressure remained in the range of 5 to 10 mm of mercury and the visual fields were stable. Thus, with early identification and proper intervention, a young patient was saved from devastating outcome and a potential blindness. The other methods of salvaging such blebs with larger areas of leak could be conjunctival autografts using various techniques and also scleral patch graft in certain situations. For example, in this patient, the conjunctival incision was made around the bleb in healthy conjunctiva and blunt dissection was performed to advance the conjunctiva. To cover the bleb completely, a relaxing incision was given and VY plasty technique was used to anchor the conjunctiva over limbus to cover the whole bleb area with healthy conjunctiva. However, as shown in this video, the conjunctival advancement was not sufficient. Hence, a conjunctival autograft was harvested from the nasal area and the bleb area was covered with the free flap before proceeding with the cataract surgery. In a situation where there is a full thickness defect causing leak, a scleral patch graft can be used to close the area followed by conjunctival coverage. In nutshell, to avoid such situations, one should be mindful regarding handling of the thin blebs while operating. A careful peribulbar block using low fluidics, avoiding fluctuations in the chamber can avoid bleb rupture while doing phacoemulsification. And in case it happens, one should not panic and plan for minimal possible intervention to close the leak. Avoid suturing in avascular areas. Small leaks can be addressed with glue and amniotic membrane. Larger leaks may require conjunctival autograft and even cadaveric scleral patch graft in extreme situations. Thank you for your kind attention.